Hypochondriasis is the topic for this video, and this is a psychiatric disorder, so let's get started. Hypochondriasis, you can kind of think of it as something that doesn't exist, in the sense that it's really, there's nothing wrong with the patient. So what the patient does, very simply, is the patient has this fear of having something wrong with them, like a serious disease, fear of a serious disease or illness. And as a result, the patient will create many symptoms and complaints to the physician, despite the fact that all the tests are normal. And this will go on, and this is often a chronic problem. So that's an extremely bare bones, brief introduction to hypochondriasis, but we'll talk a little bit more about this right now. Alright, well, let's talk about this. Hypochondriasis usually starts when the person is in their early adulthood, and it's usually equal among men or women. And the symptoms, well, the symptoms could be anything. They could be physical symptoms, you name it, from GI symptoms, they could be cardiac symptoms, like increased heart rate, you name it. Diarrhea, constipation, sweating, cramping, pain, anything really. There's no set symptoms. Any kind of symptoms. They can also vary with location, quality, duration, and they're significant because even though there's nothing wrong with the patient, this fear, the key thing here is fear, if I can spell it correctly. Fear is the main issue here. It creates a situation in the patient where it really impairs them in their jobs, impairs them in their social life, and that's a problem. That's probably the real problem. The symptoms are all fake or just imagined. And like I mentioned, this can be chronic. It can go on, and this hypochondriasis can be significantly detrimental to their day-to-day behavior and day-to-day life. So how do you diagnose it? You have to sit down with the patient and really talk about what's going on. And these symptoms, by definition, have to be greater than 6 months. And all medical tests, obviously, medical evaluation needs to be normal. And if this is done, then with usually the help of a primary doctor or a psychiatrist, we can start to treat the patient. Now, how do you treat them? Well, there's nothing to treat, right? There's nothing wrong with the patient physically, but it's more of a psychological issue. So there's a few things. The first thing, of course, is, and this is proven, that you have to create a trusting relationship with the doctor and the patient. And what the licensing exams always write is regularly scheduled appointments. Regularly scheduled appointments. And this has proven to help alleviate some of the fear and anxiety and complaints of constant symptoms. The second thing is, if needed, a psych eval to see if there is comorbid conditions such as depression or something else. And if there is indeed some depression, then adding a medication such as an SSRI can be beneficial. Alright, well, we've talked a little bit about it. Now let's get into a vignette to see what kind of stories we can find with these types of patients. So here we go. This is a big long one. 53-year-old woman comes to the office because of a discrete right-sided breast mass. She says that she discovered it in the shower 9 months ago. It has been to 6 different physicians for evaluation. None of the other physicians were able to palpate this mass, and so they told her that it must be in her head. This is the first time you are seeing the patient, so you're asked to review her complete history. She is a married homemaker and is the mother of 2 children who are both out-of-town colleges. Her husband is a traveling salesman. She has not had any medical problems in the past, and her family history is unremarkable. Menarche was at age 14, and she is still menstruating. She exercises 3 times a week, eats a low-fat diet, drinks 1 to 3 glasses of wine a week. She has normal pap smears for the past 30 years, has never had a mammogram. She tearfully tells you that her best friend died of breast cancer 2 years ago. She denies any episodes of sadness, insomnia, or feelings of hopelessness, helplessness, or guilt. Physical exam is completely normal. You cannot palpate any breast masses even after she guides you to the exact location on the right breast. You send her for a mammogram and breast sonogram and tell her that you will let her know the results as soon as they return. The results, which return in 2 days, showed normal breast tissue and no abnormalities. You have your nurse call the patient and tell her to schedule an appointment at her convenience to discuss the results. Today at the return visit, you explain the results of the test, and she still seems to feel that there's something there. You try to be as patient as possible and tell her that there is most likely no mass present. She looks at the ground and says that it will show up if you order more studies. This is a very good, rather long clinical vignette that talks basically about hypochondriasis. Okay, and you can clearly see that fear element that exists in this patient. My gut instinct is that this woman is completely normal. She doesn't have any psychiatric problems, and she even denies that. But the fact that her friend, her best friend, died 2 years ago, I think is what's causing a lot of this fear. So how do you treat it? What do you do? Advise her to voluntarily commit herself to hospital for psychiatric evaluation. That's a bit extreme at this point. Remember, that isn't done immediately. First, you have to kind of build a trusting relationship. Encourage her to get a second opinion. Well, that's just tossing the patient, and you don't want to do that. Order a CT or order a fine needle aspiration. Well, these two are further testing, and you really don't need further testing. So the next one, the last one, schedule regular weekly 15-minute appointments and recommend that she also sees a psychiatrist. This is exactly what we talked about. So the answer, of course, is E. That's what you call building a trusting relationship. And I'll finish off with a little cute little cartoon.